All right, for all who are joining, we're just going to give it another couple minutes, just make sure everybody get on. This is Micah. It's a perfect subject because this is a couple months ago. We had the folks from Boston come on and just the ones who converted like family navigation, published the papers into autism. So this is a great adjunct to that. So
That's great. Yeah, really perfect setup.
is that actually Brian Freeman? Hi, Brian. Brian saw Micah was coming. He's like, I gotta get on this call with Micah.
With
Hey,
camera
Brian.
on.
Hi, Connie. Yeah, we were saying with Mike, it's almost like I wish we didn't have a topic and we just all catch up. Like we should do like an idea happy hour. Not deal with any issues or anything. Just like all of us have a virtual string. Hi, Leandro. So we're getting up there in the numbers. Let me give it another minute or so just to make sure everyone. And as we wait, hi Amy. As we wait, we do have a pretty. We're already booked out into January, I think, for speakers now. So next month, and Angela, correct me if I'm wrong. I'm not at my work computer. We have Amy Weatherby coming next month, right, to talk about her. She can talk about whatever the hell she wants, actually, right? So whether it be like her baby navigator project, we're involved in a clinical trial with her for her ESI. So there's many things that Amy can talk about. And I just said, Amy, talk whatever you want to. So she's coming on. That'll be fascinating. And then I think the next month we have, isn't it Rosemary coming the next month, Angela? Yes.
Yep,
so
that's correct.
She's going to be talking about, she does, has published a couple of papers on her tele-PCIT work, which she's going to come talk about that, which is really cool. And then I'm also excited because in January, we're going to get an update on do you remember when we did all the work when this idea first started on the tele-ASD PEDS with Zach Warren and his group? Well, they're now publishing papers. You'll see it at INSAR coming up, I think, too, on the kids version. There's even a school age version. So they're trying to extend the age upwards on those. So they're going to come present all their new data in January. So we have like the next 3 or so months kind of mapped out, which is really nice. So again, if you guys have other people have back channeled me just different interesting topics and stuff, and we'd love to get to those if we can. I was brainstorming with Angie because there's been a couple projects that people have said, yes, we want to know more about this. Like what was the one, Angie, that everyone responded with Laura Carpenter with was it psychotic disorder?
Early onset conduct disorder.
Early onset conduct disorder versus, and like 100 people are like, yes, we should do this. But that kind of fell by the wayside. So I'm happy to facilitate another, it wouldn't be during idea time necessarily, but maybe a different webinar or something that addresses that. So there might be these special topics that crop up that if enough people say, yes, we're interested, we can at least offer and give a venue for a different time and help organize a different time for those and record it. So, and put it on our website so other people can watch it whenever they want. I think that'd be kind of cool. All right, without further ado, I cannot say, we tend to use superlatives when we talk about people, and sorry, Micah, to embarrass you, but they all are true with Micah. I've known her for a long, long time. She is literally one of the smartest people that I know. And on top of that, she's literally one of the nicest people that I know. She has this bubble around her that you enter. I remember people used to talk about where I used to work with her at a center. You would like walk by her office just to calm down because she has this like bubble of calm energy about her. And everyone says that's who works with her. She's a fantastic collaborator. She does amazing work. So now that I've embarrassed her sufficiently, I was super excited about her topic. Because we've worked with family navigation in the past, and the whole ECHO project is great with how it's extending into communities. So Micah's going to talk about the marriage of those two. So Micah, without further ado.
Thanks, Steve. Yeah, you totally embarrassed me, but I definitely really appreciate this opportunity, and thanks for the invitation. And it's actually really great to see so many familiar faces and folks who I've I've had a chance to work with over the years. And some of you have been part of the work that I'll be sharing about today. So this is going to be really fun. Let me just share my screen, make sure this is working. Is everybody able to see the screen? Okay. All right, great. Well, again, thank you so much for the chance to talk with you today and to share some of this work that we've been doing that's really focused on improving access to care, especially for underserved families who I know many of you serve in your day-to-day practices. Before I jump in, I just want to note that the work that I'm going to be sharing today is the result of a really huge team effort that involves just a huge number of collaborators, both here in Virginia, but across the US and Canada. So I want to just start by saying thanks to them and just to acknowledge that this work is, I'm presenting on behalf of a larger community of folks who've been doing this for a while now. So I just want to begin with sort of preaching to the choir a little bit and just starting with what we all know really well already. And that's that we're really facing a wave of children and families who need access to care and specialized supports in the autism field at the moment. And this is no surprise to anybody in the Zoom room today, but the prevalence of autism has increased really dramatically across the US over the past few decades. And so what that has meant for all of us in our autism centers and clinics is that more and more families are seeking help. They need access to care, specialized services across the continuum from early identification all the way through services across the lifespan. And sadly, we all know that the demand for those services and the need for those services has really outpaced our capacity to meet the demand in almost every community. And so what this has meant is it's become, I think, a crisis for all of us. And I know that all of you have been working on this in various ways in your communities as well. But I think it really keeps us up at night thinking about solutions for that and helping families really connect the dots and access care where they need it. So that's a little bit of the backdrop, I think, for today. So when we think about needs for support for children with autism and kind of those unmet needs and things that we want to do a better job with, we, of course, know that autism is a neurodevelopmental disability that affects the way the child's brain develops. And so because of that, it's very important that we capitalize on that early developmental window for intervention and learning. And so we know that we're really trying very hard to get children in for early diagnosis because that is oftentimes a ticket to early intervention. And we also know that promoting access to early intervention helps promote positive outcomes, really because it does capitalize on the time when the child's brain is poised to benefit the most from the interventions. Again, I'm preaching to the choir here, but we also know that we can identify signs of autism really early in life, in the first year of life, and in many cases can make a reliable diagnosis in toddlers by 24 months of age or earlier. But when you look at the CDC statistics, the average age of diagnosis in the US is much later than that. So it's closer to 4. And in a lot of the areas where we live, the average age is way higher than that. And then when you look at populations who have even more disparities and difficulties accessing care, the average age of diagnosis goes way higher than that. So again, this is kind of an ethical issue that I think we're all really struggling with. And so some of the needs that we want to think about are promoting early diagnosis and early identification. But we also know that autistic children and adults face a lot of other challenges that are really on top of those kind of primary characteristics of autism. They're at very high risk for co-occurring mental health problems, co-occurring medical problems, and developmental challenges. And if those challenges aren't addressed, it leads to poor health outcomes and interferes with quality of life just across the board. And we also know that those co-occurring challenges in many cases are more distressing for children and adults and their families than the primary features of autism. So those needs for support, I think, are equally or in some cases more important for us to think about holistically in trying to promote access to care and quality of life. So sadly, we know that there are all these needs that children need access to diagnosis, intervention, and support. But there's a very large body of data, and many of you have published on this, showing that children with autism have much higher rates of unmet needs for both health and mental health care services, and that as a group, they have very poor access to family-centered care and coordinated care. So that's even, compared to the general population, but also compared to children with other special healthcare needs. So there's something about autism that makes it much more challenging for kids to access evidence-based care. And families, I think, are struggling in a really unique way that makes us try to think about broader solutions for helping to improve access to care. So we've talked so far about the individual child and the child's profile of strengths and challenges and needs for support. But importantly, I think taking an ecological systems perspective is really important for any child, but especially in the context of autism, because children don't live on islands, they don't live alone. They live in the context of their communities and their families. So every one of us has people around us who support us, and children with autism have parents, caregivers, siblings, grandparents, and all of those folks are very important in fostering the child's well-being. And all of them are also affected by the challenges that children are facing and difficulties with access to care. So there are, of course, lots of bi-directional relationships there as well between the health and well-being of children and families. And each person within each system has an impact on one another. So for example, if a child is having a lot of trouble regulating behavior, that stresses the whole family. And when parents are distressed or if they have their own health or mental health challenges, they have a harder time supporting their child's needs, and they have a harder time managing, coordinating care for their child. So those relationships go both ways. But by the same token, if we can support stronger family relationships and coping skills for parents, that can help them respond more effectively to support their children. And it can also help them access care in the community more readily. So if children are not receiving access to care and they're not receiving family-centered support, that I think has downstream effects on not just the child, but the whole family. And when those families are struggling to care for their children, it leads to worse outcomes for everyone. So I think it's important to not just focus on the child-specific services, but really that family context. And then when we think a step up beyond the family, another really important system to consider is this broader system of healthcare and educational services and supports that we're all operating within. So when a child is identified as having a delay or when there's a concern for autism, families are forced to navigate a really confusing and complex maze of services and systems that oftentimes are very fragmented. So, and I think we all know this very well, that the service systems for primary care, specialty care, community-based services, EI, and education, they're all very separate from one another, and they have really confusing and sometimes antiquated systems for record keeping and for communication. They all have different funding models, and they all have different eligibility requirements, lots of forms to complete, and many times a lot of costs and co-pays. And so families, I think, really struggle to understand the system, but then also to coordinate care and connect the dots. So this leaves families kind of as a middleman in the system, and sometimes the translator between providers. So you can also think about families who may be struggling with things like literacy or for whom English is not their first language. Can you imagine navigating that system or understanding all the different forms and requirements that they need to fill out? That process could be really impossible. And then on top of that, if they're having stressors or financial difficulties, it's oftentimes just completely inaccessible for them. So there are lots of different system level barriers to accessing initial care, from the point when you're first concerned about your child all the way through to kind of following up on services to support them. So then moving up kind of at the next level in terms of an ecological systems approach, children and families also live in different communities in different regions of the country or globally. And each of those communities has different levels of access to resources. They have different services available locally and different cultures and social norms that might affect that family. And if families don't have access to some basic resources, that also has a significant impact on their ability to take care of their child. So if you think more broadly about social determinants of health, there are lots of community level factors that have a direct impact on families and children. Things like transportation and neighborhoods, safety, more difficulties around racism or discrimination, and then just economic stability and opportunities for education and employment. And all of those things add extra layers and extra barriers for families, not just in general, but also in terms of accessing services for autism. And so then finally, at the societal level, there are things that also affect ability to access care, like policy, healthcare policies and regulations, laws, and other things that affect healthcare payment and things like that, that a lot of times are outside of our control, but that are important to understand when we're supporting families. So I've said all this to kind of set the stage for us when we think about how to improve access to care. It's important to consider, again, not just the individual service or child and their specific needs, but this broader context of their family, the community in which they live, and the healthcare service systems that we're together trying to navigate, and thinking about more comprehensive ways to address these barriers to care. So these barriers, I think that we've talked about so far, all of us probably understand pretty well from working with families. The other thing that is an additional layer, I think, for autism in particular, is that we have this shortage of providers across professions who have autism expertise. And we know that our autism specialty resources are not uniformly distributed across the country. Instead, they're mostly concentrated in urban areas or near academic medical centers where most of us work. And so what that means is that across most of the country, if you take a look at this map, that would probably be in those red areas where most of the resources are located. And you can see that geographically, most of the country is pretty far from those centers. So that means that lots of families would need to drive hours and hours to access specialty care. They might need to take a day off work or more than that just to get to an appointment for their child. And so that requires resources and transportation and all the other things, just on top of the fact that it's difficult to travel that far if you have a child with autism. So lots and lots of barriers related to our shortage of autism professionals. So I think when we're understanding the barriers, we've kind of studied the problem. We know these multifaceted factors that make it tough for kids and families to get care. So when we think about the first step to try to address some of those more system level barriers, where should we really think about starting? And so the work that I've been doing with colleagues over the past several years has focused on primary care as an ideal setting as a starting point. Because those clinicians, I think, are really ideally positioned to support children and families from the very first concern. Primary care providers or primary care clinicians are community-based. They provide very timely care that's culturally competent for that community. And they also have just an ongoing relationship that with their children and families that allows them to have multiple points of contact from the very first days of life all the way through adolescence. So I think this group of clinicians is really an important group to think about when we're focusing on building capacity and helping to improve access to care. They also really are dedicated and trusted. So most families have a very close and trusting relationship with their PCP, and that makes it much more accessible and culturally relevant in a lot of cases for folks. In thinking about the role of primary care providers in caring for autism, the AAP has specific guidelines and recommendations for both care and assessment and screening for autism. And part of that includes this universal screening recommendation of routine surveillance at every visit, general developmental screening at regular visits, 9, 18, and 30 months, and then autism-specific screening at 18 and 24 months. So that's great. It provides a guideline for making sure that primary care providers are monitoring development and that they're checking for autism specifically at regular intervals. But what we don't really know exactly is whether PCPs are doing this, if they're following those guidelines, and if they feel equipped to be able to provide care for kids with autism. There have been a number of studies looking at screening practices. Most of them have looked at survey data, self-report survey data from clinicians and from caregivers. And we actually did a study a few years ago that looked at chart reviews. So we actually looked at the medical records of almost 100 pediatric PCPs just to take a look at their screening practices. And we also asked them to tell us how they felt about their confidence in their ability to screen. And the results of that study showed us that they are not, at least this group of PCPs were not universally following the guidelines for screening, as you can see here. But the good news, I think, is that we found that if they had had any prior training in autism, or if they felt greater confidence in their ability to do autism screening or work with families, those PCPs had better screening practices. So that indicated to us that this could be an opportunity to really bolster both of those things to improve screening on the ground in practices. And I think another factor to consider is that if we're going to be asking primary care providers to take on more of this work in caring for children with autism, it's also important for us to understand a little bit more about their own perspectives on that. So we did a mixed methods study of 130 PCPs where we asked them to share about barriers that they felt were getting in the way of caring for kids with autism and suggestions for improvement. So we had a checklist as well as a couple of open-ended questions about that. And when we looked at the checklist of barriers, we found that the most frequently reported barriers were that providers had a lack of confidence in managing behavior of children with autism in their clinic visits. A lot of them felt that they really didn't have time in their busy clinic schedule in a 15-minute visit to provide best practice care for kids with autism. And then lots of folks said that they felt that they didn't have good knowledge about autism resources, that they didn't have access to specialists, and that they lacked prior training in autism. And so when we looked at the qualitative information that we gathered, again, the common themes were just lacking knowledge and confidence in taking care of patients with autism, lacking knowledge about autism resources, needing more access to specialists, needing more time, reimbursement, and then access to care coordination. So these were some of the most common themes that were reported by the providers. And you can take a look at some quotes from folks that they shared. So, moving beyond just the provider level, I think we also know that even when PCPs are able to provide screening and accurately and appropriately refer children to care, or accurately screen children for autism, many of them are not making that next step of making an appropriate referral for services. So that's one kind of gap between screening and services. As we talked about earlier, the service systems themselves are really complex. And even if referrals are made, a lot of families are not able to connect with those resources that are recommended by their clinicians. So again, thinking about that ecological perspective and also about the barriers we've talked about, I think what this tells us is that we really need comprehensive approaches to bridge the gaps between screening, to diagnosis, to services, to help families connect the dots and really be able to eventually access and be able to use the services that they need. So that brings us forward to 2019, and I'm going to share about some of the work that we've been doing here at the University of Missouri to start to think about comprehensive approaches for this challenge. And in 2019, we received a grant here at UVA from HRSA to begin to think about these complex issues and try to improve access to early screening and coordinated care for families in underserved areas of Virginia. So I've been working really closely with my colleague, Beth Ellen Davis, who's a developmental and behavioral pediatrician here at UVA, along with a huge team of collaborators here and across the state. And we've been working primarily through this project with underserved regions of Virginia, and they're sort of shown generally on this map, primarily focused on the western part of the state. For those of you who are not from Virginia or not familiar with Virginia, we are located in Charlottesville here, where you can see this little UVA dot in the middle of the state. And then to the west of us and kind of up and down this region are the Blue Ridge Mountains and the Appalachian Mountains of Virginia. So this part of the state is geographically a little bit more remote from access to resources and faces some disparities in access to care that we wanted to target. So when we began this work, it was really important for us to understand those communities and to partner directly with them so that we were working together with the communities to understand what their needs were as well as what their priorities were. So we used an approach called community asset mapping, or CAM, and that is really an alternative to more traditional needs-based collaboration. It's instead of that, it's focused more on a strengths or assets-based process. So the idea is that you want to really try to build and optimize local resources and relationships, and that's important if you're wanting to think about sustainable solutions. So a traditional approach is more focused on deficits and disparities and needs, and that there's a problem to be fixed and that there's some ivory tower solution that's going to sweep in and solve the problem and then leave. So in that traditional model, it's more about doing things for communities or to communities. And if you flip the switch there towards an asset-based approach, it's really much more focused on strengths and capabilities of the community, building skills and relationships directly with partners. And the community members themselves are the co-producers of solutions that work for them within their local context. So CAM, or community asset mapping, is again a strengths-based process that begins with understanding local resources, and then it follows several steps towards co-developing solutions. So I'll kind of walk you through the steps that we engaged in here in Virginia. So the first step that you want to embark on is to try to identify the issue that you're working on. And for us, as I shared earlier, our goal is to improve access to early screening, diagnosis, and intervention for kids with autism. And we had this kind of visual model that guided some of our work to illustrate that we really want to enhance this whole pathway from screening to services. So we start with this pyramid of, just beginning with child development awareness, screening broadly, all the way up through autism diagnosis for those who need that. And then beyond that, to accessing services across some of these key domains, from family support to intervention, education, financial supports, and those kinds of things. So taking a more holistic approach there. So that was the issue that we identified. So the next step of a CAM process is to really start with having local community champions who are partnering with you in this work. And in our case, we partnered with primary care practice champions in each of those 4 regions that I showed earlier. And we worked with them to host, the champions hosted meetings in their regions with smaller groups of key stakeholders who represented community services, advocacy groups, and stakeholders with lived experience in their areas. And we held these initial meetings in each of the 4 regions. And you can see the number of attendees here on the map. And at those meetings, we talked with partners about, who in your community are the important players, who are the key stakeholders that we really need to be engaging with to try to think about solutions. And so we came up with larger invitation lists to invite a larger group of people to in-person meetings after that. So at that fourth step, we held these larger kind of a town hall style CAM meetings. And these were longer meetings that were about 3.5 to 4 hours. They included time for lunch, networking, and relationship building. And then they included a guided process of identifying community strengths, gaps, and priorities for supporting children along this pathway from screening to services. And so the meetings used this visual of pyramid to pie to kind of illustrate that pathway. So we ended up engaging about 180 stakeholder participants in these meetings, and the attendance ranged from 27 at our smallest town hall meeting up to 67 at the largest. And this happened right in the midst of COVID, actually. So our first 3 meetings were right before COVID, and then the last occurred after COVID. So it was a virtual town hall meeting. So the style was a little bit different, but the process was pretty much the same, except we weren't able to have lunch together at that one. So the way the CAM town hall process works is that you actually do visual mapping of resources. So everybody in the room at these meetings had access to lots of sticky notes. And on the walls of the room, we had kind of mapped out screening, diagnosis, therapies, educational supports in different areas of the room. And everyone would write down every resource they could think of that fit within that domain. And so at the end of that process, you can visually see where all the community strengths and assets are kind of clustered. So there may have been some areas that had a lot of resources. And then you could also see gaps where there may be fewer resources in some areas. And so then after that is visually mapped, the facilitators kind of help the team think through priorities and key issues that are emerging after you're able to see the map on the wall. And so they're taking notes, they're kind of jotting notes about those key priorities and having them on large sticky notes or on virtual boards for the virtual group. And then everybody in the room, all the stakeholders have voting dots. So they have a number of dots and they can use their vote to vote for all the same thing, or they can spread their votes across topics. And at the end of that, we're able to see where the priorities are for the community. So we tallied up all the votes and we're able to have top 3 priorities for each of the community partners. And so interestingly, even though these communities are really different from one another, the themes were very similar. So across the top priorities for these 4 regions were resource dissemination. So a lot of the communities recognized, hey, we actually have a lot of resources, but not everybody knows about them, or families may not know about how to access them. Access to care. So part of that was shortages of trained providers and then other access issues. And then the third priority was care coordination. So families were having, lots of challenges coordinating care and accessing care. And then the systems were not coordinating and collaborating with one another. So those were the top 3 kind of priority areas that were selected by the communities. So this is just an illustration of that process. So we, mapped the resources, we came up with goals and priorities, and then we worked together with the community partners to develop some strategies and solutions. So part of that began with having volunteers from each of these communities to sign up to work together. And those volunteers met as smaller groups to work on action steps at their local level. And then monthly, they gathered together virtually through a virtual learning community. And that involved sharing and learning and kind of collaborating on strategies. So here, some of the examples of that were groups focused on cross-agency collaboration. Some groups were working on training providers, and other groups were working on creating toolkits and resource guides for families. So that was some of the kind of actionable work that came out of that. But what we'll be focused on mostly today is on this integrative approach that is also a strategy that was kind of emerged out of this work. And that is the idea of addressing all three of these top priorities through integrating a provider-focused and family-focused strategy. And so that is kind of joining the work of ECHO, which I'll share a little bit more about for those of you who aren't familiar with ECHO, with family navigation. So these are two well-established models that improve access to care, but they hadn't really been integrated jointly in previous projects. So we thought for this work, this really does capitalize on some of the strengths of the communities and their priorities and allows us to test a more comprehensive approach. So taking a step back, if you're not familiar with ECHO, Project ECHO was developed at the University of New Mexico several years ago to really initially focused on hepatitis C. And the purpose of ECHO is to expand capacity for treatment of complex conditions and to improve access to care by training community-based providers in best practice care for complex conditions. So since the first publications by Sanjeev Arora in 2010 and 2011, it's really taken off and has been applied to any condition you can think of. And globally, I think the impact is really enormous. So you can go to the Project ECHO Institute website and see the just vast reach and scope of ECHO. The really cool thing I think about ECHO is that it brings together community-based providers and connects them with a specialist team of experts in whatever topic you're focused on. And it uses Zoom like we're using today, but actually was using Zoom before the pandemic, so before most of us knew what it was. It also has a community of practice kind of element. So the groups meet regularly over time, and the providers share cases that are de-identified, and they get coaching and feedback from the expert team to help improve their practice in their own communities. And they're also learning didactics to learn best practice care on particular topics. It's different from telemedicine because it's not just a one-to-one providing specialty care from a distance. It's more about the specialist training providers who then go on to treat and manage larger patient populations in their local communities. So taking a step back before this work in Virginia that I just shared about, back in 2015, when I was at the University of Missouri, I had the fortune to work with colleagues Kristen Soul, Alicia Curran, and Rachel Brown to develop and launch the first ECHO program that was focused specifically on autism. So the focus of that initial pilot program was on training PCPs in screening and management for children with autism. And so the first paper from that pilot was published in 2017. And we had a hub team that included a pediatrician, a psychologist, a child and adolescent psychiatrist. Ours was the first ECHO to include lived experience on the hub team. So we had a parent of a child with autism, Alicia Curran, a dietitian, and a social worker. And for that pilot, we were focused primarily on underserved areas of Missouri at that time. The curriculum was really built on training both for screening and for kind of understanding autism resources and following guidelines and best practice care for medical and psychiatric conditions. As I mentioned, ECHO is very case-based. So providers present cases from their own practices that they need help with. And when we looked back at the cases presented across that pilot, about half of them were focused on screening and about half of them were focused on just managing these co-occurring conditions. The most common included diet and feeding concerns, sleep problems, and then a lot of other co-occurring conditions as well. So from that very first pilot, we found that the participants showed really nice improvement in their self-efficacy. So they felt much more confident in being able to take care of children with autism in their practices. And they also improved their screening practices as well. And so those results were promising and needed to be replicated in a much larger study with more objective measures. So we received funding through the AIRP, which is funded through HRSA, to do a multi-site randomized replication study. So this project, I think some of you in the Zoom room today were part of this project as well. We had 10 collaborating sites across North America shown here. And each of those sites was trained in the Echo Autism curriculum. Each site had their own interdisciplinary hub team, and then they reached out to primary care providers in their area to train them through the Echo model. So we ended up with about 148 primary care providers who participated, and we were able to do chart review, knowledge test, as well as self-reported self-efficacy through that study. We used a partial stepped wedge design where cohorts were randomized to launch time, and we had multiple assessment points over time. So the results of the study were that we found some, not huge, but some improvements over time in their clinical practices, improvements in knowledge and self-efficacy, and reduced barriers to care from the perspective of the primary care provider. So I think this illustrates, and in our work in Virginia, really illustrates the potential for Echo to be an effective way to train providers in best practice care. And so we really wanted to take a next step, as I mentioned earlier, to think more systems level in terms of combining these provider level focus strategies with family focused strategies as well. So for the work that we've done here in Virginia, we've embedded family navigation into that model. So the project that we have, the Echo project that we have here through this work in Virginia called Links, is an enhanced version of Echo with an integration of family navigation. So this is the hub team that's been involved in the work. And I just want to highlight that 3 of the members of our team, 2 of them are family navigators, and 1 is a family education specialist who kind of works behind the scenes to pull together resources for local families. And we enhanced the curriculum of the original Echo Autism program by providing additional training on understanding systems, on kind of parent support and community resources, as well as just thinking about how to make appropriate referrals to services. We embedded some learning QI strategies within the Echo itself. So the providers were monitoring their screening and referral practices, taking data themselves, and then reporting back to the Echo on that. And they received maintenance of certification credit for that part. So in that way, we were focusing really directly on learning implementation strategies and sharing strategies with one another on what's working within the local practices and what was challenging. And so in addition to the Echo, as I mentioned, we embedded family navigation directly into the Echo program by having the family navigators directly train the primary care providers through Echo. So they shared didactics on family-centered approaches, patient-provider partnerships, and systems. They also created specific tools for families that were locally relevant. So they created resource roadmaps, infographics, and we have an online resource directory that the family navigators maintained and added resources to that is shown here called the Autism Drive. So families can go to this website. They can see a map that put their zip code in the map and see what's close to them. And they can also search and filter by keyword for specific resources directly. And then the family navigators can also use that site to create specific lists of resources that could be shared with a family based on their geography or specific needs that they have. And then we also had not only just training and resources through Echo, the providers participating in our Echo project could make direct family navigation referrals to the navigators who are on the hub team. And so those referrals, we created a red cap referral form so that the providers could refer families in their practice, specify the reason for the referral directly, or they could just share a flyer with families in their clinics, and those patients could contact the navigators directly. And so you've already heard about family navigation models, so you kind of know what that's all about, but it is really about sharing emotional support, sharing information and resources, and then in some cases, providing care coordination and ongoing navigation to directly help families connect the dots between referral and services. There are lots of different models for family navigation. I think our process is kind of illustrated here, that a referral could be made by the PCP through the ECHO itself, or a specialist, for example, in our UVA developmental pediatrics clinic could make a referral. Families could find out about it online or word of mouth, or there can be a community referral. And so depending on where that referral comes in, either the family navigator contacts the family directly if it was a direct referral, or if the family contacts the navigator, then either way, the next step is a phone intake. And then at that time, the navigator decides whether the family needs ongoing support or just kind of a one-time resource information sharing. If they need ongoing support, that could be, things like emotional support or coaching, connection with services, trying to help the family identify barriers and resources that they might not have been aware of. And then the brief support is more about like a one-time resource or just sharing information, and no ongoing support would be required in that case. So the results of our first 3 cohorts of this model were recently published, and we ended up having 3 cohorts of 42 primary care providers who participated. Most of them are pediatricians. Within the ECHO itself, 40 cases were presented, and most of the topics were related to autism screening and resources and services. So that's a little bit about the ECHO itself. Again, similar to our previous models, we saw nice improvement in PCP self-efficacy over time after participating. And then when we looked at the family navigation referrals, these were referrals directly from the PCPs participating in ECHO across these 3 cohorts. 258 families were referred for family navigation. The average age of the child was around 5, and 55% of them already had a diagnosis of autism and needed help accessing services. And then some of them did not have a diagnosis of autism yet, but had been referred for autism diagnostic assessment or needed access to other types of services. In terms of the reason for referral, accessing services was by far the most common referral question, with autism evaluation being the most common, followed by ABA, and then a variety of other kinds of services like OT or speech language therapy, and other types of supports. About 21% of referrals were directly focused on family needs and family supports. So just a very wide range of things, from families who didn't have a home and were living in a motel and needed to figure out how to access financial supports, to families without transportation and who needed help figuring out a way to get from point A to point B, learning how to apply for Medicaid waivers, or just dealing with financial stressors. Lots of different family support kind of questions. And then care coordination was a referral for about 11% of families who needed a lot of help just coordinating care across a number of different systems and providers. So when we looked at the intensity of services in terms of the level of family navigation support required, over a third of families really just needed that one-time information or education. So it was not an ongoing relationship. But about 63% of families needed what we considered short-term navigation support. So that was between, up to 3 months of working with the navigator. So more short-term. And then about 13% needed more intensive ongoing support and connection with the navigator over time, more than 3 months. So that gives you a picture of the level of the types of services and level of need that families expressed. So I think we took away from this that the results provide support that this model is feasible. We were able to do it. It was acceptable. We got high satisfaction ratings from participants and showed preliminary efficacy. And I think it might be a promising approach for taking a more holistic approach to address these complex barriers by equipping both providers and families with knowledge and support. And maybe a nice way to bridge the gap between screening, diagnosis, and services. So I know I'm short on time. I want to just mention that after these first 3 cohorts, we've really enhanced this model to take a step further to address the diagnostic bottleneck, because I think lack of capacity for autism diagnosis is a major barrier that contributes to these downstream delays that we're all dealing with. So the Echo Autism Links program that I just shared about was not focused on training providers specifically in diagnosis. It was focused more on screening, referral, and management, and then supporting families. But since that time, we've really built on the work that we started in Missouri to embrace more of a tiered diagnostic approach that helps us balance accuracy and efficiency and think about training providers to make diagnoses in some cases in the community. So I'll just quickly skip ahead to share just a little bit about that model. So the Echo Autism STAT model that we developed in Missouri in 2017 that trains PCPs for diagnosis of young children using Echo. And it's just an enhanced version of Echo that provides in-person training on the STAT, as well as training on a diagnostic interview. And then the curriculum is enhanced over 12 months to train primary care providers to make diagnoses. And so I'll just share a couple of the papers that came out of that early work in Missouri, showing that the model works and has been validated in a couple of different studies. And so since for the past couple of years, we've been now integrating this Echo Autism STAT with family navigation in Virginia. And we've trained about currently 32 primary care providers in this enhanced diagnostic model that's also integrated with family navigation. So thanks again to all the collaborators who've been involved in this work. Really huge team here at Virginia and in Missouri, as well as across the country. So I will stop sharing now and see if folks have questions.
Thank you. By the way, I mean, what I love about this is it's addressing a huge need in an evidence-based way, which is amazing. I want to open up for other people as well. I linked your paper in the chat just so people have the family navigation paper there as well. One quick question is in terms of the mechanics involved. So you have the family navigator as part of your expert team. And I know the community of learners are PCPs, but it's usually de-identified. Are these is their role? I guess what I'm asking, what are the mechanics, the actual mechanics of the family navigation role on the Echo team? Do they provide resources there, or help guide the physicians on what resources, or do they on the backside provide resource? Like what is their exact role there? Is my question.
Yeah, that's a great question. Both actually, they provide didactics on understanding community resources. So that would be a topic for one of the didactics that a navigator would present. And then for each case presentation, there's always some question about what resources are appropriate, or how can this family get access to something, or where do they need to turn in their community. So the navigators are providing case-based recommendations in the moment for those cases. And then after the session, we also have a resource library that is available to the primary care providers in Echo. So the recommendations are posted there, and then any resources or those toolkits that the navigators created are available online for the participants to access anytime. Awesome. And then they can also make direct referrals to the navigators for the navigation services for their patients as well.
If anyone else has a question, we have a couple minutes. Feel free to raise your hand and we can, or type it into chat either way. I just want to make a comment, at our center and in Missouri when we were there, far and away, the when you look at patient satisfaction, the family navigator is the one that parents and autistic individuals say, this was the most important person I met with. So it's no surprise in your communities that I love that CAM approach too. That is such a great approach to understand the communities that you're supporting. But it's no surprise that that's what they look for the most, which is incredible. And that's why, again, they respond to the problem that we have. I don't know if anyone else find this is like, unless you employ social workers, they're an unfunded source, meaning how do you support your family navigators? We talked about this last time too. It's either through a grant or the hospital just has to eat it, or which just is so frustrating, right? Because it's one of the most important roles, and yet we struggle to fund that. So does anyone have any other questions for Michael? Go ahead. Sorry, Michael, go ahead.
I was going to say that's a constant topic of conversation around family navigation. I know that some states have been successful in getting state funding or Medicaid billing for family navigation services under specific codes. So maybe that could be a future topic if people are interested.
Absolutely. Okay, I see you responded to Janice. Any other questions that folks might have? I love the echo diagnosing piece too, because we were a big part of that in Missouri. It kind of fits with kind of what we talked about here on these forums too, where there's this burgeoning evidence, across many different sources that say if the symptoms are there and they're present, people can make very accurate and reliable diagnoses at all different levels of specialty and care. STAT is great because it actually provides a quantitative way of assessing that symptom presentation. So I think that's going to be a challenge for our field moving forward. Like, how do we differentiate, those tiers and those kinds of things to make the accurate diagnosis? So,
yeah, it's really a balance of maintaining quality and accuracy and efficiency. So figuring out which are the right kids that can be quickly diagnosed in a community setting without access to a full team, and which are the ones who really need more comprehensive care.
and I mean, this is me stepping on that pedestal again. It's like it's no different than any other complex, diagnosable disorder. You can screen and you get the most obvious ones, but then the more difficult ones you send on to tertiary levels. The problem is our centers have become primary rather than tertiary centers for just about every case, which is why we have 3,000 people on our wait list and stuff. So, but Micah, thank you so much. I encourage everybody to Angela, are we on the usual time next month, or because of the holiday here in the States, are we also early for IDEA next month? Do you know?
I believe we're at the usual. I think it's I want to say the 29th, but let me check that before I say.
Reason because we the
27th.
The 27th.
It'll be the
Okay,
27th, yeah.
All right. So in November, we're on the 27th, and Dr. Amy Weatherby will be presenting on some of her vast amounts of research, on many different topics, and she's phenomenal. So make sure you attend that one as well. And also, one last thing. I was reminded the other big topic that came up was report writing. That was what just hit our IDEA listserv, and everybody responded to that. That's not a topic, I don't think, that would lend itself well to this type of forum. We don't want everyone presenting the reports that they present, but I was thinking it'd be neat to be able to coordinate not only a separate session perhaps, but a repository of report templates. There are many papers out there. Connie shared one. There's stuff in the neuropsych field way back when about pushbacks on how reports should be written, and what we should focus on. And the data is pretty consistent there. But like, for example, us in New York, we have to write reports in a very silly way so they qualify for services for our state services. And we're locked into that. So it's frustrating, but it would be interesting to so we as a group can rely on some type of consensus about, well, no, I don't know about you guys. It's like, if I can go back to my overlords and say, 90% of the centers out here write this type of report, or the one that Connie shared, a bullet point report is what the autistic individuals prefer more. So there's so many complexities. So we'll give that some thought and get back to everybody about kind of creating a repository online for even on our IDEA maybe website to say, here are some different example reports that people can use as templates. But all right, we're at time. Micah, again, thank you so much for sharing your time and expertise and amazing work there. And please just do that in every state for us. Can you come to every state and just do that same research? We would love that. So
Thanks.
have a great Halloween in October, everybody. Bye-bye.